Welcome to this special edition of ADA's Diabetes, Obesity, and Cardiometabolic Disease podcast, formerly known as Diabetes Core Update, and now with a more expansive name to fit the more expansive things we cover. Today we're going to discuss something of critical importance for all of us, and that is strategies for weight maintenance. And it is no secret that this is a challenging topic that we as clinicians and our patients are facing all of the time. I'm your host, Dr. Neil Skolnik, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University, and this special series of Diabetes, Obesity, and Cardiometabolic Disease is sponsored by Lilly. Joining us to discuss this topic is Dr. Jamie Almondoz. Dr. Almondoz is a professor of internal medicine and the medical director of the Weight Wellness Program at the University of Texas Southwestern Medical Center. He is board certified in endocrinology, diabetes and metabolism, internal medicine, and obesity medicine. Dr. Almondoz is the vice chair of the American Board of Obesity Medicine. Jamie, welcome to ADA's podcast.
Thanks so much, Neil. It's great to be here. And this is such an important topic because maintaining health gains from obesity treatment is increasingly one of the central questions that we face in practice.
It really is. And before we jump into our topic, can I ask you to share with our listeners what got you interested in obesity medicine?
Yeah, this is a great question. As an endocrinologist, I kept seeing patients with diabetes, hypertension, sleep apnea, steatotic liver disease, and all these downstream consequences of obesity, but the obesity itself was not being treated as a disease. And for me, obesity medicine gave me a way to address the upstream biology, but also being able to integrate nutrition, physical activity, behavioral support, the pharmacotherapy, and bariatric surgery in a way that we could individualize to that person. And also the stigma mattered to me. Many patients have spent years being told that if they simply tried harder, that they should be able to manage their weight. And being able to understand and to help to teach the biology of obesity makes a toxic narrative like that really difficult to defend.
I love your description, and I've never heard it put that way before, of a toxic narrative. And it really fits because as we talk to patients, just the pent-up emotion and the unneeded sense of shame and responsibility for something that is not their fault, right, is something that we hear over and over, and is so important to treatment, and I think, as we'll talk about in a little while, becomes important when we talk about maintenance as well. We know that the whole field of obesity has changed so much over the last few years. Just a few years ago, the primary non-surgical tools we had were lifestyle modification, which isn't just hard, but is in many ways, for many people, just unable to be done because, as you said, the biology of the illness. And it led to an average weight loss of about 5 to 7%, and really hard to maintain that weight loss over time. We now have powerful weight loss medicines, primarily the GLP-1 receptor agonist, semaglutide, and the dual GLP-1 receptor agonist, tirzepatide. And they lead to average weight losses now in the 15 to 22% range, a range that you and I would have only dreamed of a decade ago, now is our everyday reality. And our patients have benefited from that. The question, though, now that we're finding ourselves grappling with is, our patients have lost that weight on the medicine, and then what is the best way to maintain that weight loss and the cardiometabolic benefits that have come with the weight loss? And we have to balance that. We have to manage that with patients' values, what they want to do, as well as what's available to us. And an important part of that is our understanding of obesity as a chronic disease, which you alluded to earlier. Because if we don't really understand that, we're not going to make a logical, well-thought-out weight loss plan. Now, Donna Ryan was on here about 6 months ago, where we spent a whole episode talking about obesity as a chronic disease. But I think it's really an important linchpin of our approach to maintenance. Can you go over that a little bit again for our listeners to reinforce that?
Starting off first with kind of the concept of weight loss versus maintenance. And I think losing weight and maintaining weight are physiologic different challenges. I tell patients these are different beasts, and what got us here won't keep us here. And often these are challenging conversations because this is not what is out there in the lay literature, and it's not what people have come to accept around obesity as a chronic disease over time. And I think what's important to note is that when we lose weight or after weight loss is achieved, the body doesn't simply reset and say, hey, this is my new set point now. There's a lot of talk about set point in the medical literature, but what patients think of, well, if I just get down where I want to be, I should be able to maintain that through willpower and lifestyle, but the biology isn't there. Hunger can increase, satiety signals change, energy expenditure adapts downwards, and these biologic pressures really favor that weight regain. But unfortunately, that gets reframed to people as, in a stigmatized and biased way, hey, but you were doing so well. And I think, again, this is all part of this toxic narrative that I think we really need to undo when it comes to talking about obesity care. And I think weight maintenance is a prime example of how we should be shifting how we're talking about it with patients. Because reaching a healthier weight doesn't mean that the disease has disappeared. It's just like saying that you have a healthy blood pressure on treatment. It doesn't mean you've cured the hypertension, right? And so long-term treatment doesn't necessarily mean the same drug or the same dose forever either. It means ongoing active management of a chronic disease. And I think that's the way in which we really need to reframe how we're treating obesity and reframe how we should be targeting maintenance. Because beyond that, I think so much of how we frame it is around that number on a scale. And we shouldn't reduce weight maintenance or maintenance of therapy and obesity care to just a number. So we want to also maintain those health improvements. It's the sugars, the blood pressure, the sleep apnea. But I think more importantly, things like mobility, physical function, quality of life, the ways in which patients are able to participate in their life differently and in a way that makes them more happy, we need to focus in on capturing that and framing that as part of the long-term maintenance.
Jamie, I'm so glad you mentioned that, because it strikes me as you say that the endpoints we use in the clinical trials are all these biologic endpoints, biomarkers, A1C, blood pressure, weight. And what I hear from patients isn't about that. It's exactly what you said. It's I can go for a walk now with my kids without my feet hurting me and without the low back pain and all of that stuff that goes along with weight maintenance that we medicalize with the term quality of life, but patients say, I just feel better. And
it's stuff that you wouldn't think about had you not lived with obesity or had a similar challenge. When patients come in and say, well, what's different? What's new? And she's like, I can actually cross my legs comfortably. I didn't feel that sense of dread getting onto an airplane. I think there are so many little things and microaggressions that people living with obesity may experience that change over time that I wish they didn't have to encounter. But this is all part of the lived experience that they feel that's improving as they treat their obesity effectively.
So important. Let's move on now to talk about the evidence about weight regain after one loses weight. Can you go over that with us?
Sure. We know from many studies, including very low calorie diets or restrictive dieting and bariatric surgery, that weight recurrence is part of kind of, let's say, the withdrawal of effective treatment for obesity, and pharmacotherapy is no different. I think one of the main studies that people cite is the Step 1 extension study, which is looking at weekly semaglutide 2.4 and then following people a year out from, let's call it, abrupt discontinuation. And I think it's important for us to kind of classify what we mean when we talk about discontinuation, because in real world settings, it doesn't need to be the same way it is in a clinical trial. But of course, we need to talk beyond the weight too. I digress. So if we go back to the Step 1 extension and people abruptly discontinue semaglutide 2.4 weekly, and you follow them out for a year, the average weight regain is about 2/3 of the lost weight. And I think that's a helpful way to kind of frame things for patients, because a lot of times when you kind of say kind of relative changes in terms of body weight percentage from baseline, which is often how some things are reported out, it can be confusing for patients to understand what that means. And saying relative to how much you've lost, here's how much you could potentially regain, helps people to understand their return on investment in a lot of health and also sometimes financial ways that are meaningful to them. And I think it's important for us to know that this appears to, happen across the board when it comes to discontinuation for therapies. I think SURMOUNT-4 is an example that is often used from the tirzepatide perspective with regards to discontinuation. But then there's also evidence with regards to switching therapies recently that I think, it's important to talk about. But if we are framing obesity as a chronic and complex disease, and discontinuation of effective therapy leads to recurrence in body weight, I think that's an important thing for people to understand. But I think we're too short-sighted if we just talk about recurrence in terms of body weight alone. There was a recent post hoc analysis of the SURMOUNT-4. So this is the tirzepatide trial where people were randomized to either continue max tolerated dose of tirzepatide versus discontinuation. And what they looked at was the recurrence in body weight, but also the recurrence in cardiometabolic risk factors like blood pressure, for example. And it appeared when you stratified people out by the magnitude of weight regain, those who regained the most weight also had the biggest increase in blood pressure. And so that's one way to look at it. Another way is when you think of the role of tirzepatide and semaglutide, these are primarily or initially developed as glucose controlling agents. And so when you look at abrupt discontinuation, and people in SURMOUNT-4 didn't have diabetes, you see this rapid uptick in A1C. Granted, it's still within, a healthy normal range. But what you see is that because of the direct impact of the medication, you're going to get a worsening in glycemia. But also later on, that starts to stratify out by weight. And so I think it really speaks to the nuance of when you're treating with a medication that does more than just manage body weight and appetite, but also controls or directly manages cardiometabolic risk like glycemia. It's important for us to look at, what are our markers for maintenance long term? And if we are talking about discontinuation of effective treatment, what should our trigger be for reinitiating something or doing something differently?
That's a really good point. And we'll talk in a little while about perhaps weaning off medicines and when to, as you said, to reinitiate it. What are the signals for that reinitiation? Before we get there, and we'll talk about the different strategies, but when do you start talking to patients about weight maintenance being different than, right, we see a patient, we talk about treatment, we start a GLP-1 or dual agonist and slowly titrate up. And that involves a lot of counseling. When do you go over that at some point we're going to plateau and need to address maintenance?
Oh, from day one. I think it's so important to have this as part of shared decision making. And most patients come in asking questions like this. I think many people who have other kind of chronic health conditions related to their obesity or not are coming in trying to understand, what does long-term treatment look like for them. Many will come in saying, you know what, I don't want to start something if I'm going to be on it forever. And we hear this a lot in a variety of different practices. And from a cholesterol perspective, from an osteoporosis and other perspective, for an endocrinologist, there are a lot of things that patients will come in saying, you know what, I don't want to take something if it's forever. But that's when we talk about the goal setting and the shared decision making, and how, being on an effective treatment and effectively treating the upstream cause for a variety of health issues could in fact help to decrease their disease burden and their medication burden over time. So from day one, we have the discussion in our clinic with regards to, what does active treatment look like? And once we get there, what would maintenance look like, and how this is different for everyone. I tell patients that, that their goal is my goal. And what we don't want to do is get in our own way and drive beyond the headlights in terms of what's going to happen once we're there, because there's so much variability and heterogeneity with regards to response. I still can't predict how well someone's going to do before I give them a prescription. I think that's so key for patients to understand that we're doing this together. It's shared decision making, and that's why we need to check in with each other frequently to see how things are going.
Jamie, I'm listening, and I thought we were going to go over this prescriptive, evidence heavy stuff. And I am so thrilled. What I'm hearing is good clinical wisdom combined with evidence. And well, we both know that that's actually hard to find, right?
Well,
And it's just so refreshing because it really is true that uh, patients are all so different. And there's very few areas where that is so much the case that is with obesity treatment, both with personal experience, values, goals, and how they respond to the therapies we have. Let me let me move forward now, and it seems to me we have two very common things that occur in the office. And one are people who are just so thrilled with the weight they've lost, how they're feeling, and they are happy to stay on their medicines forever. That's one group. The other group are people who, for a range of reasons, it might be that they still have some nagging GI side effects. It might be they have insurance changes. It could be they just kind of want to come off their medicine. They don't, as you said, want to be on this, quote, lifelong. They wanted to lose some weight and then come off the medicine. Jamie, people have a lot of different goals and perspectives. They come from a lot of different places as they have achieved their weight loss goals. How do you approach weight loss maintenance? What are the different strategies that are available for us for maintenance of weight once it's been lost?
That's a great question, Neil. I mean, there are a variety of different kind of scenarios. There's so much heterogeneity in terms of what patients are experiencing and what their goals are, and that's the key to that shared decision making. For patients who are doing well and want to stay on treatment, the simplest option may be to continue their current weekly injectable, either at the current dose or a lower dose, if that continues to maintain their desired weight and also the health response. For patients who prefer a different approach, we're fortunate to have several approaches that we can take. And so talking with patients about, would change into something that, for example, is a daily oral or, in years to come, there may be, monthly injectables or other kinds of administration routes that are more preferable for patients. And I think it's about tailoring and making sure that we are matching the route of administration, but also the biology of that agent to the patient and framing in terms of here's why this treatment is individualized to you can help with and I don't want to call it the buy-in because it almost sounds like we're trying to sell something to a patient, but I think it's part of the engagement that we're not just prescribing something for the sake of it, that I think helps with that persistence and adherence beyond the body weight or their desired outcome. For those who are experiencing, mild gastrointestinal things, I think just one of the questions you ask is kind of how do we approach that where they may be wanting to discontinue? There are a few different ways to kind of look at this. Many patients we see for kind of second or third opinions for intolerance, for example, who are kind of looking for alternatives, unfortunately have not received good integration of lifestyle into their GLP-1 based therapies and really do not have appropriate, let's say, knowledge around the impacts on gastric emptying or the impact that higher fat or spicier foods or carbonated beverages might have. So even starting from a refresh of, hey, let's talk through some of the things that are helpful for people in this situation, making sure that we're addressing, constipation and nausea. I think some clinicians, unfortunately, are very quick to hand out medications that themselves have side effects when they're trying to deal with adverse effects from some of the treatments. So it's important sometimes to take stock of where people are at.
So I want to take those two things you mentioned one at a time. And the first, you mentioned the potential for changing from an injectable to an oral medicine. And can you go over briefly, there was an article recently, I think it was called the Attain Maintain study that looked at that. And how did people do with that?
Yeah. And so what that did was it took people who were taking tirzepatide and semaglutide and then randomized them to then switching to oral orforglipron. And, what we're really seeing with studies where people are then randomized to, or let's say re-randomized to either a lower dose such as in the trial where they were looking at lower doses of tirzepatide versus the attain-maintain where they were switched from max tolerated semaglutide or tirzepatide to orforglipron. What we're seeing is that you end up on the weight of the treatment to which you're newly assigned. So, so we need to then frame things in terms of what is the efficacy of the agent and temper our expectations with regards to that. So it's when you kind of look at the data then for semaglutide, people more or less maintain their weight, whereas those who are on tirzepatide, where we expect a greater magnitude of weight loss relative to semaglutide, they appear to gain some weight when switched to orforglipron. But we know that there are differences in efficacy to these treatments, but we also know that there's a lot of heterogeneity in terms of response. But of course, this is primarily framed through the lens of weight. And again, what we need to do is have those conversations with the patient with regards to what are their long-term goals, what are their trade-offs, because someone may regain some weight, which may not bother them, especially if they've exceeded their desired magnitude of weight change, but it could be maintaining, for example, their prediabetes at bay. And so it's all about that shared decision-making and the conversations around what the goals are for care, but also understanding that medications are as efficacious as they're going to be, and that we should select the right medication for the patient with the right route of administration that facilitates persistence and adherence.
So we've talked about one option is continuing their current dose of their injectable medication. Another option is continuing that same injectable medication, but perhaps at a reduced dose, slowly titrating it down to a point where someone is comfortable with not having too much food noise, yet maintaining their weight reasonably without undue effort. And another option is switching to an oral medication. Both oral semaglutide and oral orforglipron are available as those oral options. They have around the same weight loss, and both are reasonable options. I want to come back now to lifestyle, and you had mentioned the importance of lifestyle advice. Can you go over some of the specifics of the lifestyle advice you give to people who are still having some GI side effects?
Specifically for those who are having the GI side effects, it's about taking an adequate dietary history, making sure that they're aware of having smaller portions, meal size and composition with regards to kind of lower fat, less spicy foods, making sure that we're aware of kind of eating rate in terms of incorporating, let's call it intuitive eating into it, checking in with themselves, stopping before they feel full, but waiting until their hunger is gone, and that being kind of a signal to stop, adequate hydration, constipation. But I think the key thing is, so many people are linking success with dose and may have dose escalated too quickly or maybe on a higher dose than they need to achieve the health and weight improvements that they're looking for. And so I think it's hard to artificially isolate kind of nutrition and lifestyle without talking about dose at the same time.
Interesting. You know, it strikes me that in the old days, which in this case is more than 5 years ago, in the old days, we spent a lot of time when we would counsel patients about obesity, talking about these details of nutrition and physical activity. And now I think when it's done well, we still spend a lot of time. But it's often skipped over, and it remains critically important. The GLP-1 doesn't do it by itself. We're all partners in that goal of reaching success. Now, we talked about the importance of lifestyle. Any other things you want to talk about with regard to maintenance?
I think there may be patients who, for a variety of reasons, want to be on a lower dose that I think is important. Sometimes psychologically people just want to be on less medication. Mm-hmm. And, we'll frame it with regards to chronic disease management. Many patients may be on blood pressure, cholesterol medication. So we talk about if you decrease the dose, we can expect a reduction in effect, but we can work with that individual on what does dose titration look like and how do we track maintenance of success beyond body weight, including glycemia, blood pressure, etc. So I think that's kind of an important kind of conversation because in the real world, there's so many changes with regards to access and affordability. Many patients may start down a self-pay pathway and may experience changes in life circumstances where that's no longer sustainable. And they're looking for either dose reductions or changing in dosing intervals, which can be problematic. And, we talk about the different ways in which the pharmacotherapy can wear off or can cause kind of more adverse effects if it's been a while since they've had some. And so it's trying to find that balance for that individual, but working within the constraints of the real world access issues that many people face still.
Well, some important points. Now, Jamie, you talked about heterogeneity of response, and boy, we see a lot of that. And I hear a lot of patients say, without using the word heterogeneity, I'm not like everyone else. And I've been impressed that a lot of patients would like to try coming off. When I do this, I absolutely do not do what is in Surmount 4 and the long-term study you mentioned earlier. I never cold turkey someone. That I think is safe to say isn't the optimal approach. Suddenly stop medicine, but I titrate down. And one of the things I listen for, and you mentioned early, what are the indications that we need to do something differently? I have them come back or check in, and the first thing I ask about is food noise. If I'm titrating down, is it becoming more difficult to maintain the desired weight loss? And then the second thing, of course, that we look at and talk about is weight, is the scale. Are those for people who want to see if they can do reasonably well on a lower dose of medicine or possibly coming off it? I suspect some, though not many people, are able to substantially lower dose or come off it. Is that a reasonable approach?
Yeah, absolutely. This is kind of an approach we have in our practice as well. If people need to come off for a variety of different reasons, we talk about what to expect. We talk about optimization of dietary patterns to help to leverage some of the older skills, as you talked about, that we used to use around kind of fiber and protein intake and hydration to make sure that we are trying to do lifestyle satiety measures to help to counteract that. But you bring up a really excellent point that I think is often overlooked. And I think we can kind of put them under the kind of the term of the symptoms of obesity. And I think food noise is there. And I think sometimes this gets misframed by people of, or you're just hungry and this is a lack of willpower. You just need to ignore that. This is a real biologic factor. And I think this is something that can be quite distressing for patients as it comes back, especially if it comes back abruptly and strongly, because it requires a lot of cognitive load in order to work your way around it. And I think this is something that's unfortunately overlooked a lot by clinicians when we are transitioning people through therapies, for example. And it's clearly kind of ask a lot about kind of food noise and appetite and satiety and how things are changing. But I think it's important to understand that the lifestyle factors that we touched on, we shouldn't look at lifestyle as a means for off-ramping somebody for treatment and to expect the same suppression. I don't think there's any amount of fiber in the world that can silence food noise and induce satiety the same way that a highly effective medication can. I think it's unreasonable to allow patients to think that too, because unfortunately there are many influencers and other people online who talk about deprescribing and that there are a variety of different over-the-counter and other supplements that can help people to overcome these symptoms, which are very challenging to overcome.
Yeah, and those symptoms are real, and they come from where you started, the biology of the disease. You have increased appetite signaling. People who haven't experienced the overwhelming hunger that can come along with weight loss and trying to maintain or trying to lose weight in the beginning don't understand hunger signaling can be at such a high level that it is not about willpower. It's about the drive is much higher than one would ordinarily think of. So it's an important point for us to keep in mind. You've made clear, Jamie, there are a number of different approaches. The main thing is to understand our patient, to talk about their needs, to set clear goals, and to do that early, to make sure patients understand the journey they're embarking on with regard to weight loss. We're almost out of time. Any final thoughts you have for our listeners?
I'm a man of many words. And so my key takeaway really is that successful obesity treatment doesn't end when someone reaches their goal weight. That's when the maintenance begins. And if obesity is a chronic disease, we really need to have that conversation early, and we need to frame it around maintaining the health benefits that's going to require ongoing treatment in some active form. And that can include pharmacotherapy or a variety of other tools, but we need to have these conversations and understand that patients' needs are going to evolve over time.
Dr. Jamie Almondoz, thank you so much for joining us.
Thanks for having me, Neil.
And most of all, of course, as always, to our listeners, thank you for joining us on this special edition of ADA's Diabetes, Obesity, and Cardiometabolic Disease podcast, where we've discussed strategies for weight maintenance. And we didn't only go over the evidence, which we did go over, but we also had the benefit of Dr. Almondoz's clinical wisdom. And Jamie, this was great. I really both enjoyed and learned from the insights you shared, and I'm sure all of our listeners did as well. This special edition is sponsored by Lilly. We thank you for listening. For the American Diabetes Association, I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.